Let's look at the management of ventricular tachycardia and ventricular fibrillation. In a case of monomorphic ventricular tachycardia, if the patient is hemodynamically unstable, the treatment of choice would be synchronized DC shock. Synchronized here because you are timing the shock specifically to that of the QRS complex, and this is called as cardioversion. If the patient is hemodynamically stable, you can give intravenous amiodarone or procainamide or lidocaine, followed by the rhythm brought back to normal or sinus rhythm. Do catheter ablation to prevent further attacks. In the case of PVT, if the patient is having pulseless VT or if the patient is hemodynamically unstable or in shock, the treatment of choice would be unsynchronized DC shock. Here, we are not able to appreciate any pulse or there is no visible QRS complex, and hence you can give the shock anywhere. That is why it is unsynchronized. This is also called as defibrillation. If the patient is hemodynamically stable, then you can give intravenous amiodarone or intravenous lidocaine. After the rhythm is brought back to sinus, look at the QT. If the QT interval is normal, then treat the predisposing cause, acute coronary syndrome or heart failure. If the QT is prolonged, remove the precipitant for QT prolongation and treat with IV magnesium, permanent pacemaker and beta blocker. Ventricular fibrillation is a rapid, erratic electrical activity with no identifiable P waves and QRS complexes. The patient is always hemodynamically unstable. We consider pulseless monomorphic ventricular tachycardia or pulseless polymorphic ventricular tachycardia as ventricular fibrillation. The treatment of all these three would be the same, that is unsynchronized DC shock because the QRS complex is not visible and pulse is not there. And followed by this, start CPR and injection adrenaline, continue CPR according to ACLS protocol. Follow me for more such important topics. Share this to your friends to not let them lose a mark.